Thank you very much. It's very humbling to hear you describe all this history. Thank you. I want to thank you for a very kind invitation to join your group here today and to speak to you. And my task here is going to be to introduce you to structural heart disease, so the interventional therapies for structural heart disease, the past, the present, and the future. So this has been a very rapidly evolving area. I'm going to, just in the interest of time, I'm going to focus primarily on TAVR, a little bit on mitral valve replacement, percutaneous mitral valve replacement, and if we have time at the end, I'll go into some other structural technologies. So starting with aortic stenosis, I think we're very well aware of the natural history. There's a very long latent phase until patients develop symptoms. Once they develop symptoms, mortality increases very rapidly. And what I'm showing you here is the improvement in mortality with surgical intervention. So an improvement of about 50% if you can treat these patients that become symptomatic. The issue, though, with surgery is that we realize that many of the patients out there are actually not candidates for surgery. And you can see over 30% of patients with severe symptomatic aortic stenosis actually did not undergo surgery. And this applies both in the United States as well as in Europe in the pre-TAVR time frame. Now, this is from 2014, so predates obviously 2 years ago, but even then, this is from the United States. You can see that overall, symptomatic aortic stenosis in the United States is estimated to be close to 300,000 patients. And you can see that the majority of these patients are actually not being treated with either surgery or TAVR. So clearly, there's an unmet need. Now, in terms of devices, I think you're probably all very much aware of an explosion of devices and new technologies in this field. 2007 was the CE marking for both the Edwards Sapien and the CoreValve devices that you're familiar with. But you can see that there are many other devices that I don't know if I have a pointer. There are many other devices that are currently being evolving. So the Portico, the Direct Flow, the Lotus from Boston Scientific all have CE mark, are currently not approved in the United States. And there's evolution in the devices that are currently available to us. So what is the evidence for TAVR? What is the evidence? So unlike the field of stenting or angioplasty, where at least from a regulatory perspective in the United States, we started from the more simple to the more complex, with TAVR, it was approached exactly in the opposite way. We approached it from the most complex patients and going down to the more simple patients. So the very first study that was done was in inoperable patients. These were at extreme risk and really were not candidates to have surgery. And what the design, there were two studies that showed this evidence. One is the Partner 1B, and you can see here the 5-year outcomes. But this was quite staggering compared to medical therapy at 1 year and 2 years, and you can see that these outcomes are sustained at 5 years. There's about a 50% reduction in all-cause mortality with the TAVR device. With the CoreValve device, this was done in terms of a trial design a little bit differently, where it was compared to a performance goal. But again, you can see that the mortality rates here at 2 years are well below what you would expect with medical therapy. Moving on then to a slightly lower risk patient, but high risk surgical candidates, is the partner 1A. So partner 1A, you can see here the 5-year outcomes. This was a comparison head-to-head to surgery, surgical aortic valve replacement. And you can see that this study demonstrated non-inferiority to surgical replacement of the valve for the new TAVR. And on this basis, this device was approved by the FDA. You can see here for the core valve, we're looking at all-cause mortality of stroke. So once again, this device compared to surgical intervention met the non-inferiority endpoint, but actually was performed better than surgery, and that was mostly driven by a reduction in stroke compared to the surgical patients. Now, very recently, you know, earlier this month, the Food and Drug Administration actually expanded the label and indication of TAVI for intermediate risk patients. So now we're coming to lower risk patients. And again, on the basis of these data, so you're looking at 2-year outcomes here. Once again, comparing outcomes of TAVR to surgical intervention with non-inferiority to stroke and death out to 2 years. And these are data from Europe, again, showing very similar outcomes here in the European setting at 2 years compared to surgery. So in a meta-analysis, looking at combining all these studies, you're looking at a large sample size, 4,000, close to 4,000 patients. It is interesting to see that if you use the transfemoral approach as opposed to a transapical approach or transthoracic approach, it appears that the mortality is better with TAVR compared to surgical AVR. So I think this is very important. I think it certainly justifies use of TAVR in high and intermediate risk patients. Now, of course, the interventional community is never satisfied. They always want to push further, and pushing further into the lower risk cohort of patients. And what is the rationale? Well, the rationale is that with improvements in the devices from the original SAPIEN that was tested in PARTNER to now the SAPIEN 3 and lower risk patient populations, you can see that the overall mortality is declining. Steady decline, so justifying looking at lower risk patients. I think one of the big questions that comes up over and over is what is the durability of these valves long term? And I can say long term we have data out to 10 years, 11 years. These prostheses seem to hold up, but of course this is really the beginning of our experience, and I think time will tell. There are 3 studies here ongoing in the low-risk patient population. So the PARTNER 3 trial is looking at STS scores of less than 4%. The core valve study in the United States looking at an STS of less than 3 and a NOTION 2 cohort of patients, 900 patients with an STS of 4. These are all randomized clinical studies, 1-to-1 to surgery. And you can see the main endpoints. But these are all ongoing, and we will wait to see what these outcomes show. I think it's fair to say that in all the health economic analyses that have been done, whether it be from core valve or PARTNER, the TAVR is certainly very cost effective. The time to discharge is less than with surgical intervention. The length of the procedure is less. The complications tend to be less in terms of bleeding complications, kidney injury, stroke complications, etc. So in terms of resource utilization, clearly in the acute phase, it favors TAVR. I think it's noteworthy to highlight the findings in the female patient population. I've always been very interested in the outcome the interventional outcomes of women. But time and time again, in all of these studies, the outcomes of women, the mortality is lower with TAVR compared to surgical AVR. And you can see that here once again. And I think certainly for women, this is a very good therapy. All right, I just want to highlight a few of the problems that have arisen that I think are being tackled very aggressively. One being the issue of paravalvular leak. When you implant the valve, you can have a leak on the outer portion of the valve if there's poor apposition. Initially, there was a concern that even mild paravalvular leak was associated with mortality. And you can see now with repeated analyses and more detailed imaging analyses that this is really more associated with moderate or severe paravalvular leak, whereas mild paravalvular leak really has a very similar prognosis of patients with no leak or trace leak. And this has been repeated in subsequent studies. I think it's reassuring to see that with these devices, the rates of moderate and severe paravalvular leak are actually very low. They are, having said that, higher than with surgery, but nonetheless, here at 30 days, you can see very low rates of moderate or severe paravalvular leak. This is the Edwards Sapien, the one that we have the most experience with. On the other hand, this is a new device. It's not approved yet in the United States. It's a Boston Scientific Lotus device. It's a self-expanding device. And what you can see is acutely after the implantation, there is a significant number of moderate to severe paravalvular leak, but over time that really disappears with the expansion of the device. The other issue is one of stroke. This is an area that I have been extremely interested in and have published and done a lot of research here. What I've told you is that the rate of stroke is lower with TAVI compared to surgery. And I think that's important to state. Having said that, what we have seen is that with all cardiovascular procedures, and TAVI included, there is an iatrogenic risk during the procedure of stroke, and we know that. And of course, TAVI is no exception. There's an acute risk that goes down over time out to 30 days, and then this, of course, is the underlying risk of the patient population. You realize these patients have a lot of comorbidities, a lot of atrial fibrillation, and an underlying stroke risk. We have been looking at this quite intensely. Patients that undergo TAVI and have brain imaging, in virtually all patients, we will see evidence of embolization to the brain. And what we also know is for patients with stroke complications, this is one of the most important predictors of mortality. And you can see this again, whether you're looking at stroke or TIA, the risk of mortality is increased 3 to 9-fold depending on the series that you look at. So clearly an important issue to look at and to try and improve. There are a number of initiatives that are ongoing to try and reduce the stroke rate, one being procedural with protection devices, and the other being medical, and I'll show you some of these studies. We have, having looked into this, understand much better now the predictors of stroke. So there are obviously patient-related factors, atrial fibrillation, prior stroke, etc. And there are procedure-related factors, and we know that with meticulous procedural technique, the rate of stroke can come down. So I think that's also very key. What you see here is the rate of stroke overall is on the decline. So typically in these studies, we report major strokes. You can see over time, this is the early evaluations of PARTNER, and this is the more recent that was just published. You can see overall the major stroke rates are coming down because the devices have improved and because of the patient population actually being slightly lower risk. There are many studies that are ongoing, and I won't go into the details of these, but just to show you, looking at different agents, whether it be NOACs or oral anticoagulants, to reduce the risk of periprocedural and long-term stroke in this patient population. So to close on the TAVI chapter here, if you will, future outlook, I was asked to talk about the future. I think in terms of indications for TAVI, clearly patients that are at extreme risk, prohibitive risk, neither surgery nor TAVI is appropriate. The outcomes of these patients is really futile, and to be undertaking very expensive procedures is not the right way to go. Clearly an extreme risk where the patient is not an operative candidate, TAVR is the only option. In high-risk patients, both TAVR and surgical AVR is appropriate. In the intermediate risk, we've seen the United States and Europe going in that direction with now approval for these patients, and I think the question mark is going to be in the lower risk patient population, also trying to understand the durability of these valves is going to be critical in that regard. How am I doing for time? Do I have more time? 10 minutes? Okay, we'll keep going. This is just future growth estimates. You can see that there is a very bullish view on what we have ahead. All right, I'll switch and quickly go through mitral regurgitation, incidence, prevalence and treatment, and focus on some of the interventional approaches here. These are US data, 44 million patients out there with significant MR, incidence 250,000, prevalence about 2 million with symptomatic or significant MR, 2 million with MR and heart failure. And you can see once again surgery only in about 50,000 patients. So there is a gap, and there is clearly an unmet need. There's no question about this, and it's appropriately so. Many of these patients are simply not operative candidates. I think in this field, obviously, it's very critical to distinguish the primary or degenerative mitral regurgitation, which is primarily a disease of the valve itself, as opposed to secondary or functional mitral regurgitation, which is really a disease of heart failure, where the left ventricle dilates, leading to mitral regurgitation. These two entities are very, very different. We know that mortality links with the severity of mitral regurgitation, as is shown here. So the more severe the MR, the higher the mortality. This is an enormous challenge for the interventional community, and I have never seen a field explode so quickly. I'm listing here all the challenges. If I had a lot of time, I probably would go through it, but the issue is that this valve is extremely complex. It's asymmetrical. It's a high-pressure closure valve, which is certainly a challenge for durability. There are cords. It is just very, very complicated. And it is, as I just said, not one single disease. There are diseases of the valve itself, and there are diseases of heart failure leading to dilation. So when I say that this is a very active area for innovation, here you have it. So 2016, this is a list of all the various companies coming up with new technologies, innovations, trying to treat this mitral valve. I'm not going to go through all of them, thankfully, but basically they fall into three categories. You have the edge-to-edge, the mitral clip, which is the one that is commonly used. You have a whole number of devices that are annuloplasty devices, and a number of devices that are truly replacement, percutaneous mitral replacement devices. In terms of approval in Europe, you can see here there are not that many. This is mitral clip. I'll review that for you. This is an annuloplasty device. There's cords, and this is another annuloplasty or cinching device, as is Valtech. So let me just very briefly give you sort of a high-level review of mitral clip. So this is an edge-to-edge. It's, as you can see, it's a clip that is placed across the atrial septum down into the left ventricle, and that actually clips the valves together to try and reduce the amount of mitral regurgitation. This is the worldwide usage in 2016, so over 30,000 patients have been treated with this. And interestingly, the majority of patients treated are those with functional mitral regurgitation, whereas the indication, at least in the United States, is for degenerative MR, so it's sort of the reverse. The evidence that led to approval of this device, I think, is relatively weak. So this is based on 300 patients with a mixed population here of degenerative and functional. It was a randomized trial of surgery versus the device with follow-up. And here's the take-home. Essentially, there was no difference in mortality over time between surgery and the device. At the end of the procedure, of course, there was a lot more residual mitral regurgitation, severe mitral regurgitation with the clip compared to surgery. But having said that, the symptoms were similar. There was an improvement in symptoms with the device compared to, that was similar to surgery. But again, the issue here is that this is a very mixed patient population. Most of these patients, 70%, were degenerative, 30% were functional. And what is fascinating is to look at the outcomes here. I think we would expect this. The outcomes were similar between the clip and surgery for degenerative, but you can see with the functional, the outcomes are much worse. Why is that? Well, it's heart failure. Heart failure is the primary underlying issue in that patient population, and I would say that even the role of surgery is poorly defined for functional mitral regurg. So on that basis, they got approval for degenerative disease. Now, the COAP trial, one that we're involved with here at Yale, is the first study that will be looking at the mitral clip compared to medical therapy in a cohort of patients with functional mitral regurgitation. So I think we need to wait for these results to better understand the role of this device in that population. I'm not going to go through this. This is just more devices, annuloplasty devices, cords and leaflets, and here a whole host of different stent-based replacement valves in the mitral position. You can see here very few patients enrolled. These are truly at the pilot phase. So this is the very early evaluation of these technologies. So many challenges. I think I've made that very clear in terms of delivery, fixation, because there is not a true annulus as in the aortic position. Issues of sealing. This is not a symmetrical entity, so there's issues there. And of course, because of the proximity of the aortic valve, issues with potential left outflow obstruction may be concerning. So just looking here, this was a slide I had in 2010, looking at the prospects to 2016, i.e. now. I would say that the experience with mitral clip has actually exceeded the projections, and I think that is quite phenomenal. And again, I think we need the data, we need COAP to better understand the role here. So do I have time to finish up here, or do you want me to wrap up? Okay, so 5 minutes. Okay. So other technologies, I think in this space, heart failure is going to be very, in the future now, is going to be a big area of interest for percutaneous interventions. Clearly, the prevalence is extremely high here. Numbers in Europe, you're looking at 15 million patients in Europe with heart failure. So clearly this is prime for the interventional community and innovators that are really sort of chomping at the bit to find some solutions here. Very high mortality, very high readmission rates in this patient population. A number of new technologies currently being evaluated, particularly sensors, monitors, LV remodeling devices, etc., in this space, and microVAD. So I think this is going to be a very interesting and rich space for the interventional community. This is one device that we are involved with at Yale. It's called the parachute device. It's essentially a partitioning device. This is for patients with an anterior infarct and left ventricular and apical aneurysm. And you can see that this device is placed in the apex and excludes the aneurysmal dilatation. The data coming out of Europe actually is very, very promising with this. And again, we're in the midst of a randomized pivotal trial in the United States. And I thought this would be interesting also to show. So this is a permanent implant for pulmonary artery monitoring that basically feeds back to the physician and enables adjustments in medical therapy. So this actually has been tested in a randomized clinical trial of 500 patients, demonstrating reduction in readmission rates and improved outcomes. So I think a lot of excitement in the interventional community with, particularly in the structural space. And I think that as we move forward and we think about these innovations, we need to reinvent ourselves all the time. And this was a little signal to my good friend, John Lefteriades. We need to be out there and think big and think about the future. Thank you very much for your attention.
Thank you, Dr. Lansky.